carry on now with the third session, and this is actually the anesthesiologists section. So I think we'll be starting with an online presentation on current standards of coagulation monitoring and therapy after cardiopulmonary bypass use by Dr. Erdoes. Yes.
Hello, everybody. Can you hear me?
Yes.
John, thank you very much for this nice introduction and for inviting me to give this lecture. So, can you see my screen? Can you see my screen? Hello, can you see my screen?
Yes.
Okay, so thank you very much. I don't have any, only one conflict of interest. I'm a member of the steering committee, but otherwise no conflict of interest. So I think coagulation monitoring and therapy is very important, especially if you would like to avoid any bloody footprints of the surgeon on the floor. You should be aware about coagulation monitoring and therapy. We all know this term CBP-related coagulopathy. There are different classes of bleeding, and from the literature, we know that severe bleeding can occur in 10% of all patients undergoing cardiac surgery on bypass, and transfusion is necessary between 20 and 40%. If the patient is bleeding, if we transfuse blood products, there is an association to an increase in adverse outcome and mortality. What is the etiology of CBP-related coagulopathy? There are different etiologies. First of all, the hemodilution of the patient blood by the priming solution, by fluids given to the patient, loss of coagulation factors. It is partially related to surgical bleeding, leading to a consumptive coagulopathy, a consumption of coagulation factors in the extrinsic pathway, but also in the intrinsic pathway, and of course, residual heparin or protamine overdose can contribute to post-CBP bleeding. And what is the consequence? We will have an impaired thrombin generation, a depletion of coagulation factors, reduced platelet count and function, hypofibrinogemia, and hyperfibrinolysis. If you are looking again at the pathophysiology, you can see here that peripartum hemorrhage, trauma, and CBP-related bleeding have common pathways, especially here with hemorrhage, with tissue damage, with dilution, and all this stuff here. The consequences of this bleeding are similar between these different pathophysiologies. And there is also a relation to other systems, to the complement system, to the inflammation system, to the fibrinolysis system. So each system can activate another system and vice versa. What are conventional or viscoelastic results in laboratory results after a CBP run? You see here there is a worsening in the coagulation. And if you would like to some laboratory tests, the conventional laboratory is not sufficient to lead to a diagnose. All these laboratory values need a long turnaround time, and it is difficult to interpret them and to initiate a therapy only on the basis of them. On the other side, we have viscoelastic point of care tests. and they are very easy to obtain, and they are mostly implemented in guidelines. But I will show you that in detail. We can use this viscoelastic testing. We have different machines normally in Europe and also in US in the ORs. Of course, we have this ACT machine to diagnose, to test heparin effect, but ACT can be also increased in hypothermia, hemodilution, in case of low platelets, and in case of low factor deficiency. So this is not an appropriate machine to diagnose the heparin effect. It is more a general test. We have another device, the HMS machine, which tests heparin dose response. So if you are using this machine, you can exactly calculate your heparin and protamine dose. And of course, we have ROTEM and TEG, which are blood tests and have a quick performance. And with this test, you can diagnose almost every problems in your coagulation cascade. If you would like to especially diagnose platelet function or dysfunction, we have the possibility to use the multiplate device, which however requires training and time and dedicated personnel, and it is not available in every OR. In Bern, we have a new device. This is the ClotPro device. It is working like the ROTEM device, but it has additional assays. So I'm meaning especially the Russell-Viper-Venom assay to diagnose factor 10 inhibitors, and also the ECA assay to diagnose factor 2 inhibitors. And it is also a good assay to diagnose the effect of tranexamic acid, the TPA test, and we are using all this test if it is necessary in our patients. So what are the pillars to diagnose CPP-related coagulopathy? These are the point-of-care viscoelastic tests. They are feasible on CPP, so you can have the test results just after weaning from bypass. They are whole blood analysis, and they provide huge information about your coagulation cascade, but also on fibrinolysis and platelet function. They are very rapid, so the test results are available after 5 or 10 minutes, and it has been shown that if you are using this test, you can reduce your transfusion requirements and the frequency of transfusion as well. These tests are not perfect, of course. There are variations in target and trigger values, and if the test is performed in the OR, so not in the laboratory, there could be some quality issues, and there is no prediction possible regarding bleeding. So a patient with normal point-of-care test can bleed, and also vice versa. The most important thing is that you have a transfusion algorithm in your hospital. And this is just an example from the SCA, how to use a transfusion algorithm and how to use different options to treat coagulopathy. If you are going back to the standard laboratory test and the point-of-care laboratory test, of course, we have some trigger values for both of them, but there's, again, to say that there's a huge difference between trigger values according to devices and society recommendations. What can we do in a case of massive hemorrhage? In my opinion, there are no trigger values, and you should transfuse as in a trauma patient to prevent development of severe coagulopathy and to maintain perfusion and to reduce end organ transfusion. So you give normally RBC, FFP, and platelets in 1:1:1 ratio. And monitoring is difficult, but you could use all the normal monitoring tools you have normally in the OR, the central venous pressure, you have the transesophageal echo, urine output, and so on. Let's talk about different substances. Tranexamic acid, I suppose everybody of us are using tranexamic acid. There are many studies in the literature. We know that there's a dose-dependent effect of tranexamic acid, and we know also that tranexamic acid can be associated with seizures, especially in open heart surgery. And we know also that the high infusion rate versus low infusion rate of tranexamic acid can make a difference, and that it is recommended now in the literature to reduce the tranexamic acid bolus and infusion rate, because the effect on the coagulation cascade should be the same. And there are different protocols. In my hospital, we are using the protocol from Zafre and collaborators. You see it in this column group 2. So we are only administering a bolus of tranexamic acid just after anesthesia induction, landing by 1,600 milligrams in an 80-kilogram patient, and it is working very well. And coming back to our test devices, you can monitor the effect of tranexamic acid with a TPA test from the ClotPro device. What about the fibrinogen supplementation? We all know this REPLACE study, which was a multi-center study, showed that fibrinogen supplementation was associated with increased transfusions. But we all know, again, that this study was highly biased. It was a multi-center study, but only few transfusions were given, and different centers use different protocols, different algorithms. So a very heterogeneous study. On the other side, we know that we don't need high levels of fibrinogen. So a level just above 1.5 gram per liter or 8 millimeters in the point of care test would be enough to treat adequately this patient. And this is now also in the recommendations. This is an old recommendation from 2019, again from the SCA. They are saying that fibrinogen concentrate may be considered for significant post-bypass bleeding. I suppose nowadays, when new guidelines will come out, we will switch to a more strength recommendation saying that fibrinogen concentrate should be considered in significant post-bypass bleeding if the patient is hypofibrinogenic. What about PCC concentrates? Studies could show that with PCC, patients are getting less cumulative transfusions, and in comparison to a treatment with FFP, and the literature and evidence supports also the superiority of PCC in comparison to FFP. What about FFP administration? We know that fibrinogen has a very high concentration in FFP, so almost 90% of factors in one FFP concentrate is fibrinogen, but FFP is not sufficient to increase significantly the fibrinogen level in a hypofibrinogen patient. You see here, if you would like to increase the plasma fibrinogen level from 0.5 to 1.5 only with FFP, you would need 20 units of FFP in comparison to only 4 grams of fibrinogen. But we can administer FFP. FFP is indicated especially in case of excessive bleeding with coagulation factor deficiency, and maybe also considered, as I mentioned before, as part of massive transfusion protocols. So based on recent guidelines, we did a review and published it in Anesthesiology, stating how much dose should be given from different drugs. This is just a summary to show you. What about factor 7? It is only for hemophilia. It can use also in cardiac surgery with high bleeding rates. Nowadays, we use much lower doses as recommended from the company. So in most of the cases, 10 or 13 micrograms per kilogram would be effective. Factor 13 should it be. It is not in the guidelines. There are not too much. We don't know that. So especially in terms of factor 13, we need further studies, especially in cardiac surgery, to have more information about this therapeutic option. And last but not least, to treat severe coagulopathy, you can also use the open chest approach in some cases. So I'm coming to the end of my presentation. I have several take-home messages. Conventional laboratory tests are not useful to diagnose and manage post-CPP coagulopathy. Close fibrinogen is a very good test, but it is not anymore the gold standard to diagnose hypofibrinogemia. Instead of that, we should use point-of-care viscoelastic testing, which is a very rapid test, and it is part of many algorithms. And we know from the literature that point-of-care viscoelastic tests could demonstrate a benefit in transfusion requirements, but not in improvement of mortality. And I think these are the reasons for that. Many centers are using, there are center-specific effects, and centers are using different trigger values and different definitions for severe bleeding, and we don't have well-conducted multi-center studies. So the guideline adherence is poor, unfortunately, and point-of-care test devices are not widely available. I think the key for success is a good background information to know that bleeding is multifactorial and that one single intervention will never achieve improved morbidity and mortality. And we discussed it, or you discussed it previously, the societies are also responsible to organize, evaluate, summarize, and disseminate knowledge with minimal invasive circuits, and also with bleeding or treatment of bleeding of patients undergoing cardiac surgery. So thank you very much for your attention, and have a nice day in Thessaloniki.
is growing evidence that in the case of massive bleeding, is possible to use whole blood. There are some data from military environment. Do you any experience or comments?
No, whole blood is, I think, in Europe is not an option. It could be an option in different parts of the world, but not in Europe. I think a modern hemostatic therapy should use factors and different parts of the blood, but not whole blood. We have all the possibilities here in Europe and US, so whole blood is not really an option. We don't use it here.
Yeah, that certainly has been our experience. It's very difficult to get access to whole blood. One of the things we haven't done a formal study on it yet, but we've started measuring fibrinogens when the patient comes into the operating theater. We're trying to incorporate this as part of our preoperative assessment. But we've been finding a significant number of patients come in with very low levels of fibrinogen, about 20 to 30% of patients, which is very surprising. We haven't come up with a particular etiology yet, whether it's the medications they're on or what, but I don't know if that's been anybody else's experience, but I think a number of our patients are presenting with the increased potential for coagulopathy because of hypofibrinogenemia.
Yes, it's very interesting. That's true, Professor Murkin. A lot of times there is a pre-existing hypofibrinogemia, and that's why we try not to treat numbers after point-of-care testing. When I see we follow the same algorithm with Dr. Erdoes, and in case that low value is indicated, I always check the surgical field, so we don't want to treat numbers, because a lot of times there is this pre-existing hypofibrinogemia.
John, my experience is there could be two reasons for hypofibrinogemia preoperatively. One reason is dilution of hemodilution of the patient. So if patients are getting too much fluids in the preoperative period, and the other one is if the patient is bleeding chronically. So in chronic diseases with ongoing bleeding, there is a consumption of coagulatory factors, and the first factor which is then lowering is fibrinogen. So for me, these are the two reasons for preoperative hypofibrinogemia.
Yeah. I think certainly excess fluid administration, a dilutional can certainly contribute. But I say it's been our observation when I've seen some of these patients in the preoperative clinic. They're coming in de novo with low levels of fibrinogen, which again we're unclear as to why. It's just one of those observations, and we're hoping to do a study moving forward to try to identify this. But anecdotally, it does seem that those patients are more prone to bleeding. The ones where we've identified it preoperatively, we follow them that much more closely, and potentially use cryo was one of our first interventions when after the heparin's been reversed. So I think there's a lot more work to be done.
Agreed.
Okay. Well, thank you very much.
Yes, we must move on. The next speaker